Thank you, Dr. Faisal. Now I would like to call upon our next speaker, Dr. GAZELLA WARJRI. She is working as a consultant in LVPI, and Dr. GAZELLA would be speaking on lasers for angle closure glaucoma. Over to you, GAZELLA.
Good morning, everyone. I'd like to talk about laser peripheral iridotomy and laser iridoplasty because, as we all know, there are a lot of cases of angle closure in our country. So, as we all know, in laser peripheral iridotomy, we make an opening to prevent the relative pupillary block. So, many lasers have been described for this, but what we commonly use is the Nd:YAG. So, many indications are there seen from this list. These include PSC, PSCG, the fellow eye of acute angle closure. Sometimes some people do it for a phacomorphic glaucoma, although this is not very much advised. Aphakic or pseudophakic pupillary block, nanophthalmos microspherophakia, and plateau iris, phakic IOL sometimes, pigmentary glaucoma, or to deepen a narrow angle before laser trabeculoplasty. So when do we do it in PACS? Only in the fellow eye of the other eye having acute attack, patients who cannot come for frequent follow-ups, patients who require dilatation like diabetic patients, one-eyed, or patients with family history of glaucoma. There are many difficult situations which we can face. Suppose the patient is unable to cooperate or sit on the slit lamp. If there is any opaque or cloudy cornea, thick iris, if there is a widely dilated pupil which is not getting constricted, or if there is flat anterior chamber with iridocorneal touch. And some contraindications for laser PI is if it does not decrease the pupillary block, like if there is ongoing inflammation, rubeosis iridis, or like eye syndrome, or any neovascular membranes closing the angle. So we use the Abraham lens because it improves visualization and helps to stabilize the eye, and also for magnification. And on top of this, it focuses and increases the power and minimizes the epithelial burns on the cornea. So where do we like to select the treatment site? Usually between the middle and peripheral third of the iris, and 11 and 1 o'clock meridians is supposed to be preferable. And a large crypt or an area of thin iris is usually taken as the site. So iridotomies within the palpebral fissure can cause visual disturbances, and we should also avoid iridotomy where the lid margin bisects it. And in silicone oil, of course, we know we should do it inferiorly to avoid blockage by the oil. So like we talked about just now, we have to take an informed consent and use pilocarpine and topical anesthesia. And as we know, laser settings, anything between 4 to 7 millijoules, and we use a posterior focus. So of course, we have to sit the patient at the slit lamp and identify the region of the crypt after we have put the lens on the patient, and focus the aiming beam with the posterior offset, and then we try to perforate the iris, of course, after which we'll see a gush of fluid, and we try to enlarge it till a minimum of 150 to 200 microns. In this small video, we'll just show the gush of fluid which happens.
Identify a thin region in the depth of a crypt or in an area evidenced by a rather lacy transluminant appearance. Now, aim the laser beam onto the superior and peripheral part of the iris. Focus the 4 spots of the helium neon beam, manipulating the spots until they merge into one. The shock wave travels towards the surgeon from the point of focus. It is helpful to have the focal point within the iris stroma. For this, one has to focus the laser beam precisely on the surface of the iris and then use the posterior offset option, making it converge 0.1 mm in the iris stroma. The endpoint of the procedure is the mushrooming of the pigment into the anterior chamber.
So as we can see here, these are two iridotomies which can be seen, and they are supposed to be ideal iridotomy sites. So in cases of acute angle closure, it is one difficult situation. So we have to, if it's not possible to do it much in the periphery, we can do in the mid periphery also, where the pupil is most constricted, and we should use a oblique illumination with a narrow beam so that the site will be properly visualized because of presence of corneal edema. So like we talked about the endpoint, there should be this mushroom cloud of pigments with visible gush of aqueous, and sometimes there will be deepening of anterior chamber, or if there is a pupillary block, decrease in iris bombay. So post laser regimen, we have to check for the patency of the PI and IOP after the procedure and give topical steroids for a week and recall the patient after 1 week to reassess the PI patency. And we have to do an IOP and repeat the gonioscopy to confirm if the pupillary block is relieved or if there are other non-pupillary block mechanisms, and check for HVF and optic disc. So what is sequential PI? This is when we use a double frequency Nd:YAG to create a peripheral crater in cases of very thick iris, and then we complete the iridotomy with Nd:YAG. So as we can see from this animation, that first we use the frequency doubled Nd:YAG, then the Nd:YAG. So when do we do sequential PI? If there is thick or dark iris, or on patients who are on anticoagulants which cannot be stopped to prevent or decrease the bleeding, and those who have friable iris as in uveitis or neovascularization. So advantages is it reduces the energy required and also decreases the hyphema. So what are the complications that can happen in LPI? We can have post-laser IOP spikes, most common, uveitis, pupillary distortion, cataract, corneal epithelial defects or corneal burns, bleeding, hyphema also sometimes common, diplopia, ghost images, visual dysphotopsias. There can be closure of the iridotomy or any retinal or macular burns. So this transient IOP rise, of course, we treat it by giving glaucoma medications. Depending on the amount of glaucoma, we may need to give oral astazolamide as well. Then iritis can be minimized by the corticosteroid drops. Hyphema is usually self-limiting, and when we see it happen, any bleeding during the procedure, we should press the lens on the eye so that this will reduce the bleeding. So endothelial damage used to occur a lot earlier when argon was used. Now it is reduced, but it can happen in cases where the AC is very shallow. Visual dysphotopsias, some patients do complain of blurring, glares, halos, some development of shadows or spots after the PI, which can be very disturbing for the patient. So many studies have showed where should we do the PI to reduce all these symptoms. So according to Vera et al., they said that they randomized patients to superior and temporal PI, and those who had temporal PI had a decrease of these symptoms. But of course, other studies were there as well, which showed that these symptoms were not dependent on the location of the PI, so more studies are required here. So if there is failure to perforate, we can either tell the patient to wait for some time in the clinic only and repeat the procedure after the debris have reduced, or we can call the patient after 1 to 3 days. But of course, in acute attack, it's very important to have a patent iridotomy at the first sitting only. Late closure can happen if the iridotomy is made very small initially. So next we come to laser iridoplasty. So here it is two open and appositionally closed angles in which either iridotomy cannot be performed, or if iridotomy has been done but the closure is not opened. So as we see in this photo, we place contraction burns using laser of longer duration, lower power and larger spot size in the extreme iris periphery, so that there is contraction of the iris stroma, so that this will physically pull open the angle. So these are indicated in acute angle closure along with the PI, chronic angle syndrome. Mostly it is used for plateau iris syndrome, or in some cases in angle closure due to the lens, and as an adjunct to laser trabeculoplasty to open the angle. Contraindications are if there is severe and extensive corneal edema, flat anterior chamber, or cynical angle closure. So we use it in an acute angle closure attack, especially if the corneal edema is very much. So this is to open up the angle so that, or thin out the iris so that we can do a laser iridotomy. So of course, because iridoplasty does not eliminate the pupillary block, we have to do a PI in these cases. So plateau iris, like we already talked about, this is because the angle remains appositionally closed or occludable following the laser iridotomy, so we need to do the iridoplasty. So if pupillary block is either not a component mechanism, it will not be eliminated by PI, so we have to do a laser iridotomy. As a laser iridoplasty, as seen in this UBM photo, where the angle has opened up after the procedure. Again, pre-treatment measures are similar to iridotomy only, and these are the laser parameters: spot size 500 micron, and duration is 0.5 to 0.7 seconds with power of 240 milliwatts. So again, we use the Abraham iridotomy contact lens, and usually we ask the patient to look in the same direction or the quadrant of the iris being treated, and we can use a foot pedal or trigger depending on the machine, and see for the entire duration of the burn unless there is bubble formation and pigment release. So the desired end is that we want to see the iris contraction at the treated site, and we should reduce the energy if we see that there is charring of the iris or formation of gas bubbles, or if
Gazella,
there
you
is a
need to
pop
conclude
sound.
now.
So post-laser protocol is again like iridotomy. Complications can be similar, like iritis, increase in IOP, or corneal endothelial burns. So the take clinic message is that ideal site for doing a PI should be in the middle and third peripheral third of iris, 11 o'clock. And in patients with thick iris, we can do sequential PI. And laser iridoplasty helps in opening this apogee closed angle. Thank you.